Bismillah ar-Rahman ar-Rahim. Today we will talk about right-sided obstructive lesions, the tetralogy of Fallot, and the pulmonary stenosis and pulmonary atresia, and the Epstein anomaly. These are the topics, the three pathologies that we will talk, the four pathologies that we will talk about. First, the tetralogy of Fallot. The tetralogy of Fallot is a tetralogy. There are four pathologies that describe this syndrome or this pathology. The pulmonary stenosis, the overriding of the aorta over a VSD, and the RV hypertrophy. These four pathologies are the cause of only one original anomaly. So the tetralogy of Fallot is actually a single anomaly that resulted in this tetralogy. So the primary pathology is the anterior deviation of the coronal septum towards the pulmonary artery anteriorly. So when this coronal septum is displaced anteriorly, it detaches from the remainder of the interventricular septum, or rather not detached, but a lack of fusion of these parts of the septum occur. So a VSD results. This conoventricular VSD allows the blood from the right ventricle to go to the aorta, because the stenosis renders the forward flow to the pulmonary artery difficult, so it is easier for the blood to go from the right ventricle to the aorta. And when the septum moves anteriorly, it narrows the pulmonary artery and widens the aorta, so the aorta overrides the septum. So we have overriding of the aorta. So a VSD, a pulmonary stenosis, overriding of the aorta, and because the right ventricle is opposed with a stenosed pulmonary artery and the aortic pressure or the systemic vascular resistance, so the right ventricle hypertrophies. So these are the four pathologies that we find in the tetralogy of Fallot. They are associated with some other anomalies, like coronary artery anomaly, usually the left anterior descending, or an infundibular artery originating from the right coronary artery crossing the RVOT, or a coronal branch of the LAD crossing the RVOT. These arteries that cross the RVOT, whether the LAD itself, the infundibular artery, or the coronal branch of the LAD, they limit the possibility for an RVOT patch, because if we cut open the RVOT, we may injure the coronary. So an RVOT patch is not possible, and the solution is RV to PA conduit. Sometimes the pulmonary valve is bicuspid with thickened leaflet tethering of the pulmonary artery wall to the pulmonary artery wall. Sometimes there are multiple VSDs, generally in the muscular septum. Sometimes these muscular VSDs are not apparent at the beginning, because due to the main VSD or the conoventricular VSD, the large VSD, so blood finds it easier to pass through the main VSD, and the other VSDs are potentially closed, or they are not closed, but blood doesn't pass through it, so they can't be seen by imaging, by echo or CT. So when we close the main VSD, blood passes through the multiple VSDs or the extra VSDs, residual VSDs, and they are found post-operatively. Those multiple VSDs cause post-operative pulmonary congestion. Sometimes they are closed spontaneously if they are muscular. And if we try to close them, sutures may damage the conducting system, causing heart block or bundle branch block. And they may necessitate repeated cardiopulmonary bypass runs to close them. So sometimes the presence of multiple VSDs that are large or multiple and would cause significant hemodynamic affection or pulmonary congestion post-operative render this patient non-operative. And the single ventricle pathway is tread until they close spontaneously or the patient grows up or we find some other solution. But otherwise, a shunt or a Glen is the temporary solution for this problem. Discontinuous pulmonary arteries. Proximal left pulmonary artery near the ductal insertion has ductal tissue that narrows after birth. So ductal tissue is affected by oxygen after delivery. So any part of the vessels that has migrated ductal tissue, like the proximal LPE, or in cases of coarctation of the aorta, sometimes the ductal tissue migrates to the proximal descending aorta. So after birth, they narrow and try to close the descending aorta, and a coarctation results. We have also ASD and PFO. Sometimes they are left to vent a right-sided high pressure. If the pulmonary valve repair is difficult, and a residual stenosis, significant stenosis is expected, so we may need to leave a vent. Right aortic arch determines the site of the MBT shunt. Also, partial or total anomalous pulmonary venous drainage, persistent left SVC, AV canal, atrioventricular canal, PDA, patent ductus arteriosus, interrupted IVC in inferior vena cava, anomalous coronaries and anomalous pulmonaries. Sometimes there are syndromes associated with fallow, like trisomies 18, 21, 13, vectoral charge, and Alagille syndromes. Chromosome 20q11 microdeletion associated syndromes like DiGeorge syndrome, velocardiofacial syndrome, and conotruncal anomaly face syndrome. This is the 20q11 microdeletion. Those are the anomalies. We have conotruncal defects like fallow, pulmonary atresia VSD or interrupted aortic arch, or truncus arteriosus. Immune deficiency because of deficiency in the thymus gland, hypocalcemia because of deficiency in the parathyroid gland, facial and velopharyngeal anomalies that may cause difficult intubation. Trisomy 21 Down syndrome, usually AV canal defects with hypothyroidism, hearing loss, hypotonia. Trisomy 18 cardiac anomaly plus respiratory insufficiencies, horseshoe kidneys, omphalocele, tracheoesophageal fistula, cerebral hypoplasia, corpus callosum agenesis, spina bifida, micrognathias, microphthalmia, and colobomas. Trisomy 13 cardiac anomalies with respiratory insufficiency, renal abnormality, dysphagia, holoprosencephaly, microcephaly, spina bifida, orofacial cleft, microphthalmia, coloboma. As for vectoral syndrome, you will notice that these syndromes are tedious to study and to memorize. But they are important, because if we are faced with one of them, If we do not have these associations in mind, we may be faced with problems. So unfortunately, we should know these things. Vactral syndrome, vertebral anomalies, anal anesthesia, cardiac anomalies, retardation of growth, tracheoesophageal fistula, esophageal atresia, radial and renal dysplasia, limb abnormalities. So it is vectoral. As for charge, coloboma in the eye, heart abnormalities, choanal atresia, retardation of growth, genital hypoplasia, and ear anomalies. For Alagille syndromes, cardiac with hepatic biliary duct paucity, there are few biliary ducts, renal abnormalities, skeletal abnormalities in the vertebrae, ophthalmological and facial, Holt-Oram syndrome, cardiac and upper limb. So going back to the fellow, age and weight. You should know the age and weight of the patient. Baseline saturation can range from severe cyanosis and duct dependent to pink fellow, to even lung congestion. So it depends on many factors: the pulmonary stenosis and the degree of overriding, the presence of other sources of blood supply to the lungs. Neonates are born usually as acyanotic, then later the pulmonary artery closes and the infundibulum hypertrophies. History of spells. So the spells appear in the form of patients getting bluer with syncope, maybe fits. We ask about frequency, severity, and how they get relieved, either spontaneously or with calming down the patient or whatever. Spells can be triggered by pain and stress, dehydration, which is common before surgery due to fasting, acidosis, and this acidosis is sometimes occur in the form of a vicious cycle. So spells cause cyanosis, and cyanosis causes decreased oxygen delivery to tissues. So lactate is produced, causing acidosis, causing more spells, and so on in a vicious cycle. Fever, decreased systemic vascular resistance, severe cyanosis causes more acidosis, vicious cycle. History of low cardiac output, failure to thrive. Severity depends on gradient across the RVUT, dynamic obstruction at the infundibulum, because the entire coronal septum is deviated anteriorly, so the stenosis in fallow is usually valvular and subvalvular. So the subvalvular part is a muscular part, so the obstruction becomes dynamic. Other sources of pulmonary perfusion like PDA or MAPCAS, mean aortopulmonary connecting arteries, hemoglobin level and hematocrit, polycythemia. It is beneficial to increase oxygen carrying capacity, especially in severe cyanosis, but it increases viscosity and risk of thrombosis. So we avoid decreasing hemoglobin less than 10, because even 10 is considered low because of the oxygen carrying capacity, because the polycythemia is beneficial for the patient, but too much hemoglobin or RBCs cause increased viscosity and risk of thrombosis. So we avoid decreasing hemoglobin less than 10 and increasing more than 20. And these patients sometimes undergo regular phlebotomies. We check the coagulation profile, history of embolism, either thromboembolism from the polycythemia or paradoxical embolism from the right to left shunting across the VSD. May have anomalous coronaries, for example the LAD or conal branch from it passing in front of the RVT, rendering the repair difficult and may get injured, like we said before. Chest X-ray, the heart is boot-shaped with oligemia in the lungs. Usually needs a CT scan to check the anatomy of the aorta, the great vessels, the pulmonary arteries, the coronaries, the PDA and the MAPCAS. we should put in mind that there are two important variants of fallow, or the fallow with pulmonary atresia. Sometimes we call it extreme fallow, and the fallow with an absent pulmonary valve. Sometimes people assume that the absent pulmonary valve is a pulmonary atresia. No, the absent pulmonary valve is the absence of leaflets in the pulmonary valve. So the blood flows antegrade normally through the pulmonary artery to the pulmonary artery, but without a pulmonary valve. So in this case there is free pulmonary gauge. So in pulmonary atresia, the main pulmonary artery may be absent, MAPCAs are present, and the patient may be PDE dependent. Surgical correction is usually difficult, and in cases of PDE dependent neonates, it is a surgical emergency needing PDE stenting or MPT shunt, because the PDE closes after birth. So so the patients are born cyanosed with progressive cyanosis. In absent pulmonary valve, there is a pulmonary stenosis and free pulmonary gauge due to lack of pulmonary valve or leaflets, lack of leaflets. And in utero, the pulmonary arteries become hugely enlarged, and the neonate is born cyanotic with respiratory distress and air trapping if the large pulmonary arteries are compressing the bronchi and are causing bronchomalacia. Total surgery for surgical, there is total repair at infancy. Sometimes it's done in neonates, but usually in infancy. VSD closure, pulmonary valve repair, or RVOT and RVOT patch. Sometimes if there's supravalvular stenosis, pulmonary arteries repair. Otherwise, transannular patch if the pulmonary valve is unrepairable, if this is dysplastic or the annulus is very small. RV to PA conduit if the coronaries pass anterior to the pulmonary valve, as we said before. Balloon dilatation, PDE stenting, RVOT stenting, or MPT shunt may be needed in small neonates with severe cyanosis or duct dependent. MPT shunt may be done if the pulmonary arteries are small, to allow increased flow and growth for lateral total repair. And the MPT shunt is usually a temporary solution, because leaving an MPT shunt may cause pulmonary hypertension later. In pulmonary atresia with MAPCAs, unifocalization may be made. This is the main pulmonary artery repair. This is the RVOT patch, and these are the two. Or otherwise a transalveolar patch, a long patch traversing the pulmonary valve to repair the whole RVOT. And this is the VSD closure. This is the normal anatomy. The LVD is a branch from the left main. This is the conal branch from the right coronary, passing through the pulmonary valve. And this is an anomalous origin of the LAD from the right coronary. So the LAD itself passes in front of the RVT. This is an algorithm. If fallow tetralogy is symptomatic, we check the age. If it is too young, we do a shunt. If it is from 1 to 6 months, but but less than 4 kilos, we do a shunt. If more than 4 kilos or the patient is more than 6 months, we do a repair. If the patient is asymptomatic, we wait till the patient is more than 4 months or 4 kilograms, and we do a total repair. This is the MPT shunt. These are old shunts that are not done anymore, but this is the MPT shunt, modified Blalock-Taussig shunt between the right subclavian artery and the pulmonary artery, the right pulmonary artery. Before induction, we avoid agitation by pre-medication and mild sedation in a monitored setting, because we have to keep in mind that this patient is cyanotic. So if the sedation is heavier and the patient is hypoventilated or even obstructed, so he may deteriorate rapidly, or cyanosis may progress rapidly. Use sugar drops and pacifiers to calm down the patient. Minimize fasting and dehydration. Continue beta blockers till the day of the operation. Keep hemodynamic goals. Preload, maintain high preload due to the infundibular and RV stiffness. Maintain normal rate and avoid tachycardia, and maintain sinus rhythm. These patients, because of the stenosis and the RV hypertrophy, so they cannot tolerate tachycardia and arrhythmia. Contractility, avoid increasing contractility. Avoid reasons that increase sympathetic stimulation, like so we should maintain good analgesia and good anesthesia. Avoid hypercapnia, hypothermia, and hypoglycemia that may induce a sympathetic response. High systemic vascular resistance by vasopressors to force the blood away from the aorta to the pulmonary artery. And vasopressors should not have an inotropic effect, so we should not give ephedrine, for example, or adrenaline. We should give phenylephrine and to a lesser extent noradrenaline. Low pulmonary vascular resistance, so increase FiO2, decrease CO2, and avoid acidosis. Be very careful with inhalation induction if needed, and better avoid inhalation not to lower systemic vascular resistance. So ketamine IV or IM can be used. It's a good idea to use ketamine IM, because if the patient comes with a cannula, it would be easy. We would give midazolam and ketamine IV, and the patient would go to sleep. But if the patient has no cannula, so I am facing with either inhalation induction with the patient stressed and crying, so this stress may and inhalation, in the high dose of inhalation anesthesia itself may cause spells in the patient. And if I try to insert a cannula, he may also cry, and this crying may induce a spell. So it is better to give an IM dose of ketamine, 4 mg per kg, while the patient is with his mother. Even if he cries a little from the injection, it will only be for some seconds, and the mother may take him away to calm down. And then within 20 minutes, he starts to lose consciousness, and then you take him quickly to the OR. And then you can insert the cannula while the patient is calm and monitored. So this is a good idea. So IM ketamine with atropine, IM sick from the vial into the outer aspect of the middle thigh, and then waiting for like 10 minutes with the patient in his mother, with his mother, and then when he starts losing consciousness, you take him to the OR. Avoid anemia to maintain oxygen content more than aerobic threshold. If the spell occurs, first you give phenylephrine or noradrenaline to quickly reverse the shunt towards the pulmonary artery. Then 100% oxygen, ensure adequate ventilation, give fluids, check the depth of anesthesia, maybe the patient is aware or stressed or in pain. Then take an ABG sample to correct PCO2, acidosis, and hypoglycemia that may have caused sympathetic response. Warm the patient, and then give propranolol or esmolol, If no response, ask the surgeon to manually compress the aorta and go on bypass or ECMO as soon as possible. So the first line for these patients with an acute spell under anesthesia is vasopressors, oxygen and fluids. But the first line for a patient with recurrent spells in the outpatient clinic is a propranolol, because propranolol prevents the incidence of spells or decreases the incidence of spells. But during the spell itself, during an emergency situation, propranolol will not help much. It is used, but not as a first line. So don't get confused. The first line for treating of spells intraoperative is noradrenaline or phenylephrine, and the first line in treating of spells in the outpatient clinic is propranolol or beta blockers. We see in the TEE anterior and leftward deviation of the coronal septum. Check the gradient across the RVT, valvular, subvalvular, and supravalvular. Pulmonary valve may be thick, dysplastic, or bicuspid. Measure the annulus and try to decide whether the valve is repairable or not. VSD and the direction of flow across other anomalies. This is the long axis, mediasophageal long axis. This is the aorta enlarged with and overriding the interventricular septum, and this is the VSD. And you can see during systole, blood flows from the right ventricle to the aorta. It becomes red during systole. This is in the RV inflow outflow. You can see the VSD, blood flowing from the RV to the aorta. And this is the stenosis, the pulmonary stenosis. It starts from an infundibular stenosis, and there is a valvular or even supravalvular stenosis here. So it is a multi-level stenosis. This is a valvular stenosis with the annulus looks fine. The diameter of the annulus looks fine, and the leaflets look fine. They are not dysplastic or thickened or anything, but apparently they are fused or something. So there is resistance to flow at the orifice, the pulmonary valve area. So the erasing starts from here, and this case may be treated with Hager dilatation or commissurotomy without patches. In cases of absent pulmonary valve, patients, maybe neonates, high PEEP is needed to keep open the bronchi that may have bronchomalacia. Prone position may help. TE is relatively contraindicated, not to compress the respiratory airways more. Respiratory distress may persist after surgery. Post-cardiopulmonary bypass, we check the oxygen level, the saturation, we check the RV pressure directly, either by TE, the RVT gradient, or directly by needle inserted into the RV and connected to a transducer to measure the pressure directly in the RV. The RV should be less than 2/3 the LV pressure or the aortic pressure. If residual VSD is suspected, we do a step up of oxygen. The step up is done by measuring the oxygen content in a sample, an ABG sample taken from the right atrium and the pulmonary artery. If the saturation increases in the pulmonary artery compared to the right atrium, it means that significant oxygenated blood was added to the blood in the pulmonary artery at the level of the right ventricle. Yeah. So this indicates the presence of significant VSD shunt, and left to right shunting across the VSD. There is a risk of coagulopathy. Platelets may be thrombocytemic due to polycythemia. Polycythemia causes the bone marrow to be hyperactive. and this hyperactive bone marrow may produce and publish platelets that are not fully mature, causing thrombocythemia. So prepare adequate blood products, especially fresh blood and platelets. Usually need inotropes and good filling to support the hypertrophied RV. The CVP is a good monitor of the RV function. Inotropes are needed because the RV dysfunction is expected due to possibility of poor preservation of the hypertrophied RV on cardiopulmonary bypass, ventriculotomy, the long cardioplegia time, and the coronary abnormalities. Conduction abnormalities and heart block because the bundle of His crosses at the posterior inferior edge of the VSD and near the anteroseptal leaflet of the tricuspid valve. So during suturing of the patch to the edges of the rims of the VSD, the bundle fist may get injured. Jet is common. If heart block occurs, we put a temporary pacemaker and we wait for a few days, so that maybe the bundle of his was not totally injured. Maybe it is edematous or something. So we wait for healing. But if healing does not occur and the heart block persists, so we will need a pacemaker, permanent pacemaker. Jet is common. There is a heart rate more than 170 and AV dissociation. The treatment of jet is difficult. We may attempt to override pacing. We pace the heart more than the rate of the jet, and then slowing down the pacing rate. So maybe the SA node will recover or take over. We may give sedation. We may correct electrolyte abnormalities, cooling to 34 to 30 or 35, amiodarone, dexmedetomidine infusion. But generally, a jet is difficult to treat. In cases of pink fallow with high RVOT gradient, indicating the presence of MAPCAS. So sometimes if the gradient is 100 or something, and I find the patient not synosing, so I suspect the presence of MAPCAS, it is expected that post-repair the lung will congest, and dealing with the MAPCAS surgically or percutaneously is essential if possible. This is a residual stenosis and residual regurg. Thank you.